Wanted to welcome everybody again. We have about 30 people in the audience. Really good to have you here. Happy May, uh, almost May 1st. Hard to believe we're that far into the year already, but it's awesome to have you all join us today. Let me grab my screen here, and we're going to share a little bit this morning on insurance contracting. All right. Well, again, welcome. So this is our second installment of our five pillars of financial effectiveness. Um, for those of you who weren't able to join us for the first webinar series, our first session, it was on a physician relationship, physician contracting, a little look across the industry on various contractings and things to think about when you're looking at that. So if you'd like a copy of that, I'm sure we could get you a copy. Reach out to us, let us know. We'll be happy to get you a copy of that. So today we're going to talk about insurance contracting. Exciting stuff, right? But looking at how do you maximize that payer relationship and reimbursement. So a little bit about who I am. If you don't know, I'm Steve Febus. I'm with DZA and as a director of advisory solutions. Now, I've been with the organization slightly over 6 months, almost 7 months, but I have 38 years of uh, hospital experience, both on a PPS side and critical access hospital side. So have been through multiple layers of contracting in my time in my career. Um, I've negotiated some successful ones, and I've been challenged on others, as we probably all have at some level. So lots of opportunities to learn. Today, our primary focus is just general understanding. And so we're going to walk through this. There's so much specificity to the organization themselves, to the payer in that relationship, the market, the community itself, and who you serve. So those are just nuances that we won't be able to get that deep into it. But at some level, as you're thinking about insurance contracting and what that looks like, how do we begin to frame up that opportunity? So I'm available at any point if you ever want to pick my brain, or anybody on the DZA team, just kind of general overviews or thoughts. We're happy to help in any capacity and just kind of guide and get you down the road. Ultimately, my heart in doing this and why I shifted away from being a CFO of a hospital facility is to really help a lot of hospitals and position ourselves in terms of where we're going into the future. We know it's going to be a rocky road. So how do we get ahead of that and help drive the organization instead of just being reactionary and then trying to survive, but how do we thrive? So let me start with the disclaimer. Notice this is just general information, blah, blah, blah. But just mainly educational components to it. Nothing too deep here anyway. But we really want to just get out in front of you. So what are we going to talk about today? So what is this payer contracting? What does it mean? What's the basic concept? So, I know that the audience is going to be really diverse in its nature. We're going to have people who are just interested in understanding, may not have a lot of concept and ideas, to people that have been doing this for decades and just want some refresher and let it, almost that reassurance that they're on the right path. So we've tried to structure this to be that where you're getting a little bit of both. What's the current state of the payer contracting, especially in rural healthcare? That's primary my focus. That will have that bent. Contract review and assessment frameworks, what you should be thinking about, and then what analytics, what should you be pulling, or how do you prepare for this? And then ultimately that negotiation process, and then did it actually result in what we expected it to? And so that's where we're heading today. So, real general overview. This is Insurance Contracts 101. what the heck is this thing we're talking about when we say, what is payer contracting? What does that mean? Well, core idea really is the payer contracting is that fundamental agreement between the provider and the payer organization. It provides that framework of how you get paid, not only how you get paid, but why you get paid, what gets covered. So some of you may have expanded services, but if you didn't have it in the agreement, then it would be a non-covered service. So you might start seeing denials on certain aspects when you thought you were contracted. Well, that's because that service may not be covered and you actually didn't notify the carrier and renegotiate that piece. So, it's got that whole reimbursement terms. What are your requirements? We're going to talk a little bit of what you need to be thinking about when you're looking at that contract. And then ultimately, why does it matter? Because end of the day, it's how we get paid. It's how we survive. It's about our clientele and making sure that we're doing what we need to do for authorizations, the process in order that patients can actually come to our facilities. So ultimately, there's a blend when we're thinking about a contract, either from a fee to service, but some are beginning to meld the two into some type of value-based incentive process. And so that's what we're talking about when we start talking about payer contracting. When we think about what are the primary information within the contract, let me take one step back here because I think it's an often overmissed component, and that is the definitions section. You will see that on the bottom down there. It says definition section is the framework. Why do I say that? Because that's the umbrella. That's what exists over the entire contract. So understanding that section is super critical. It is often the cause of much contract pain. So definitions should be long. They also provide the critical rules for policy updates, the level of care, redirects, etc. All of that is defined within it. So make sure you're looking at the definitions. But once you get into the heart of the contract, you begin to look at these primary areas. One is payment terms. So what are the payment terms? That's really, how are you going to get paid? Is it a fee schedule? Is it some type of APC? Is it a percent of charge? Some contracts might be a little bit of all that. It could be, per diem. So this is really outlines for you that reimbursement side of it. Then you look at the clinical rules that are associated with it. So those are policy updates. Those are the level of care and how they might redirect care. Some insurance companies now are requiring, even if you can do it at your facility at the same cost to them for certain elective procedures like a colonoscopy, they were requiring it to go to an ambulatory surgery center. And so they might redirect care. So you want to make sure that do they have that ability to do that with even your contract? Yeah. Even though your contract might say all services are covered, all of a sudden they're redirecting care outside of it. So is that a breach of contract? Is that a lever point in which you can have discussions? Those are things that you want to make sure you understand within your contractual relationship. The operational clauses. So how do we go about credentialing providers and even that word alone, I'm sure many of you are like, oh yeah, I wish our credentialing team could do a better job and get providers in quicker. That's across America. That's not your team. Sometimes that's just payers are not quick at getting providers through their system. And that clogs everything up. We have a provider that is ready to care for patients, but they can't because we haven't got them credentialed and therefore we can't see the patient. So the claim submission rules, timely filing, underpayment, overpayment. How does that impact our ability to, make sure that they can't come back later and take information away? So understanding that whole operational side of it, that is information that was within your contract. The term in the agreement, the renewal, that no cause termination, how do we cure something in which we disagree on? All of that is under the term and agreement. And of course, what types of services can you provide? And then ultimately, the real last piece is this whole risk allocation. So how do we manage disputes? We disagree. I believe the contract says, you believe it says this. How do we manage that? And how do we get visibility into that section? So those are the primary framework when you're looking at your contract and trying to understand them. Be looking at what does that mean, and then how does that best facilitate our facility. So there's a little bit of the outline in terms of just the basic understanding of insurance contracting 101 and trying to get your arms around, okay, what are we talking about here? But now we're in the economic reality. So how do we think about this negotiations? We've had this climbing escalation in costs, labor, supplies, etc. Is reimbursement keeping up with that? And many of your contracts might be capped out. They may have, you can raise your prices only up to an aggregate of, maybe 3%, 5%, but your cost went up 10. Well, how are you negotiating that? And all of a sudden your margins are declining as a result of that. So you're sitting here thinking, oh my gosh, we've got to renegotiate this. But I know all of you that are sitting in the seats of that finance team, revenue cycle team that is talking about this is like, yeah, do we really want to? And we're going to talk about pros and cons of both sides of that. But there really hasn't been any meaningful rate increases in the last 10 years to providers. And that's been a struggle for all of us. And that's why you see declining margins across the nation. And if you think about that pro fee schedule, sometimes our frequent updates, but are those frequent updates improving due to really the budget constraints of CMS? All of a sudden, updates are non-favorable. And so things are updating, but all of a sudden our reimbursements gets less. That's not good. When our costs, I don't know how many people have actually reduced their wage costs by reductions in salaries and benefits. And especially providers, especially with the shortages of providers, that is not happening. So understanding, just kind of sometimes rate increases sound good on the outside, but they might increase the conversion factor, but also the weights went down, so you make less. Understanding what that looks like and realizing that's probably why your margins are collapsing. So let's take a step back and say, why would payers leave contracts unchanged? Why don't they want to touch this? Well, some do. And I will tell you, many that are coming to you and saying, hey, we need to look at our contract. It's probably because they want to not only change your reimbursement structure, but honestly, it's probably wanting to change your language. And that can be very problematic for the provider community. And we'll talk a little bit about the why. But right now, we're going to talk about why payers just leave contracts unchanged. Well, one, because sometimes them not changing this is better for them. Uh, Sometimes when you go through this and status quo, they know exactly what their margins are. They don't want to mess with that. If they do give increases, all of a sudden that puts pressure on the payer side in terms of their obligations to their stockholders or their owners or whomever it might be. The responsibility lands honestly on the providers to initiate the contract. Um, I think especially in rural healthcare, sometimes we're often forgot about. We may not be, a large part of the business. So as long as things are going along fine, then contracts go unchanged. Additionally, without data and persistence, the status quo remains the same. If I will tell you right now, the insurance companies have a lot more data, a lot more data repository. They get all that claims data. And you think about like the blues of the United States today and sharing of information, all of a sudden they have a lot more than we do. Now with price transparency, that whole playing field is beginning to level out. However, how much time do we as providers have to actually go and data mine that and actually do something with that? That's the challenge, right? I mean, that's ultimately where we just don't have a strong enough bench. And so payers, we're at a disadvantage to the payer and what they know compared to what we know. And so we get in front of a payer and we start saying we need more. And they're like, actually, you get paid more than X, Y, or Z down the street, and so we actually want to pay you less. And then all of a sudden, I wish I'd never made that call. So anyway, it's just that continued, concerns as to am I going to get favorable rates from the provider side? What are some of the challenges we think of when we're talking about this whole contract negotiations and why they largely go unchanged? Well, one, it's just a fear of losing what we have today. Plain and simple. There's contracts I am happy I had. I didn't want to rock the boat. I knew what was coming in. So I'm hesitant to go out and try to get more when I'm afraid that at the end of the day, they probably have more data than I do, and they're actually going to want to negotiate less. Like, well, I'd rather just leave it alone. There's uncertain negotiating language. We're just not clear. What should we be thinking about? I think many hospitals, especially rural hospitals, um, really feel they have a disadvantage here. There's old language within our contracts, and we're thinking that maybe we ought to negotiate that. I will tell you, there's sometimes old contracts are more favorable in language than new contracts. So uh, you can get into a new contract relationship, and all of a sudden the language gives the provide or the payer universal authority to change the contract without ever talking to you. That's not good. And so those are aspects of why sometimes it's better off just leaving the contract in place and maybe negotiating an amendment on just payment alone. So there are things to think about in terms of how you would want to approach it. Also, probably the biggest thing I think most of us face is just time. Um, Look across the board here to my right, and I'm looking at the sheer amount of to-dos as I sit in the seat of a CFO right now, and I'm just like overwhelmed by just the day-to-day stuff. And that's just if I can get to it and not have to deal with the fires that came up right now. So that's one of the challenges we have. And then we are concerned not only about the damaging of that payer relationship, but we're concerned about what it means to the community. And I think ultimately that's our driving force. I remember having some discussion with my board of commissioners and the senior leadership team about approaching a contract negotiations. And in that discussion, I'm like, where's our willingness to really put the line in the sand? And there was so much concern about the community impact that we couldn't find the line. We just could never draw it. And that really put us at a disadvantage of really having a strong negotiating component to it. So what is the strategy? Why is it important? Well, think about it. Um, what's a 3% revenue upside mean to the organization? If we just took just a simple example and say, let's say it's 100 million a year, and I know some organizations would say I would die for 100 million in gross charges, and others would go, well, I'm three times that. But I mean, it's just a little easier to use that type of number. But you think of a 1 to 3% uptick, all of a sudden that downstream impact of that is a seven-figure impact to your bottom line, and that's quite astonishing. If you try to get that same seven-figure impact, even the 2% here, thinking about contractual write-offs, et cetera, payer mix, you know, uh, end of the day, it could be $1 million. But what are you going to have to cut out to save $1 million? Well, most facilities of any size, you're probably looking at 20 FTE and to get that same equivalent. And so that's the challenge we have. We can't cut our way to profitability. So we got to strengthen the revenue cycle. One aspect of that strengthening of the revenue cycle is contract negotiations. So the other, I think, interesting thing HFMA cited in a survey, the whole 67% of policy friction between the payers and providers. And that's the problem. We all face it, right? We've got denials for non-auth, or we've got to jump through all these hoops in order to get a patient into our door or through our systems. And that's the challenge. We also challenged with just getting information technology, leveraging what we have. So much of our payer mix are starting to begin to deploy a lot of AI. We in rural settings haven't been able to keep up with that growing technology as effectively. And so we're faced with sometimes denials that just make no sense. But if our teams aren't educated enough, we end up just writing it off because they're busy. Revenue cycle team just ends up, putting it to contractual and we don't see visibility into it. And all of a sudden we wonder why our contractual expense is going up when we're seeing more volume and it's not making sense. Well, some of it could just be AI generated denials or line item denials or things that we aren't seeing visibility in. So understanding that, that's why strategically we need to be thinking about how to improve this whole revenue cycle functionality. I have seen, I think probably many of you have this concept of take it or leave it reality. Um, some of our large systems sometimes feel like and I've seen it actually happen where they just walk away from unfavorable terms. They just cancel the contract altogether and say, we're done. And the reason they can do that is because they have leverage. I think in small rural hospitals, we often feel like we have less leverage. And so then we feel a little bit fearful of just that pushback. And that could be just even pushback within a community, right? You might have one of your larger providers, and let's say they have one of the blues, and you're going to discontinue that contract. And all of a sudden you're getting the calls from, those employees or senior leaderships in that particular community calling you as the administrator or CFO saying, what were you thinking? How could you do that to us? We aren't going to have access to care, blah, blah, blah. So we're really sensitive to that community need. But the reality of it is that pair needs to have the market. They need to have access to care in order to provide the product. And that is basically sell insurance. So they do need you. So you do have more leverage than you actually think. And that's I think one of I think our pitfalls on really understanding that do we truly have the leverage? We do. And so I would tell you right now that the payers pit themselves against each other and competition is very stiff. So we can leverage that to the best of our ability to make sure we're getting good contracts that help our sustainability really in the long term. So now we're at the point where, yeah, I really do think it's time to negotiate. Where do I even start? I don't have time in my day. What's next? So this slide is really talking about what's next. Often the hospital has one or two payers with really bad contracts that are totally out of a line with the rest of them. So when I say assess your payer mix, that's really important. You can look at that and say, okay, our top payer is I should negotiate, but that may not be. You might have really strong contract with that particular payer. That shouldn't be your primary focus. It should actually be these other payers that are more challenging to your organization. But decide which path makes the most sense to you. Begin to set your goals. What are your expectations? Start to build your case study as to why. Use claims data, use other payer data. There's a lot of really a plethora of information out there, especially with price transparency today, where you can actually begin to see what others are getting, and that might provide some leverage. But ultimately, it's also your community. It's also where you are as an organization. I mean, you want to be relevant, you want to be sustainable, you want to be around in 5 years from now. And you might be struggling. So it is really time to renegotiate those terms. They, the payer need to have you continue to provide those services, or they lose clients because they don't have access. So that's an important factor when you're going down that list. So I'm going to have a couple slides here, a little bit of high level, and then it may feel a little bit redundant, but it's really trying to take that high level and then digest it and say, what are the key components? My hope here was to provide you information that you could actually then begin to say, how do I frame this up? So read and understand your contract. One thing you can do is you can use some of the AI generated reviews to say, what is the summary of this? And you definitely need to understand it yourself because AI is not the case study here, but understand the duration, understand the renewals, know what the reimbursement terminology is. What are my payment timelines? What are my requirements for timely filing? Do I understand what my strategy is for population health as we look to the future? And what do I want to bring into the community to help support that population health? Is it within my contract today? Do I need to look at it tomorrow? And then ultimately begin to have conversations as you go into this with those that could be impacted, some of your local community relationships that you might want to pull in and say, hey, we're going to go start having some discussions with Aetna. Here's the reality of what we're facing. We understand that that may have impact on the other side of that, and that is from the employer side, cost increases. But I think just helping people understand where you are as an organization in full transparency is important. So as we begin to dive behind this and say, okay, now we're going to take this another step below. What's kind of that first read and understand your contract? This would kind of provides an outline of that reimbursement methodologies. What do I want to accomplish? Can I even do that? I had one payer carrier that wanted us to move to a whole different payment system. My current software that I had didn't support that. As a result of that, I pushed back heavily and saying, we just can't. And this just isn't supportable on our end. And so by able to share that, we were able to avoid something that we couldn't have managed anyway. Then build your CPT DRG revenue database. Pull your informations, pull your 835s and 837s, get the information behind that. Look at what your other payers are doing. Take those top 20 or 30 and identify what are you getting now and what would you like to do and what does that mean for you downstream long term, especially in your margin? How does that correlate to your ultimate goals? And then what are your prioritization for negotiations? Is it market share? Are you losing market? Why is that? Is it operational alignment? Whatever those might be, those components, those value propositions, maybe you're developing new services or maybe you're the only one in the area. So what are those things that you have strong negotiating um, components as you head into discussions? And then analyze, frame up your data, model it out, compare it against your Medicare, other regional rural benchmarks, et cetera. One of the things I'm going to talk about as we progress through this, you might be saying right now, because I know it popped in my head, is I don't have time for this. Do I get somebody else to help me, and what would that look like? So I think that's really I want to frame up what that might look like and why you would even think about should I do this in-house or do I need to outsource support? I would not advocate one way or another. I did it both ways in my career. But it's largely um, dependent really on this. If you can manage it internally, it gives you direct control over your strategy. You know exactly what your service line priorities are, and you know those payer relationships. Because at the end of the day, you're going to continue to have those relationships. So it's really critical to understand that component. You know where your organization fits. The main thing you got to understand is do I have the bandwidth? Do I have the capacity? Do I understand the information? And do I have the support underneath me from the organizational um, structure to make this happen? If not, then outsourcing might be something to consider. Um, can they provide that service expertise that you need in order to be successful? And know that this is going to take probably longer than you think it is. So just making sure that they have the capacity and they're focused on your needs generally. So really that success again depends on clear governance. You got to own it. It's yours. But do they have access to get the data? And then do they have aligned incentives for results? If you do decide that outsourcing makes the right sense, these are the things you should be thinking about. What are your time constraints? When are you hoping to get this done? I have seen some that have lingered on for 4 years and no progress. And I tell you, if you're sitting in a CFO seat, you're probably frustrated. Your CEO is probably wondering, why haven't we made progress? And it might be that each of us are just have kind of let it slip. So, what's the cadence? How often do we need to meet? What's the expectation? Do we know what the right partner is for us? Do we have that aligned? What is that whole amount of revenue going out? Have we talked to our providers? Have we looked at any of our referral out information? And do we understand that? So that can help you to frame up how developing this relationship with outside support can be important. So kind of now more thinking about, here we are, we're ready to prepare our negotiations. Um, Love to just go say, hey, we want, more money. And I'm sure payers are like, okay, how much? And they're ready to pay you tomorrow. That doesn't happen, right? I mean, that's very facetious, but we all would love that to be the case. But you need specific information on what your request is. If you're vague, they'll be basically fed to the lions. So you need that understanding of your own data, where you're trying to get to, and why. So think about that through your process. Know where you're willing just to walk away. Where's that number that we're not talking anymore because we're going to be greatly impacted here. So that's definitely a place to begin to start thinking about what is it we have to have end of the day and how do we make that happen. Sometimes you see, and I would caution this, and within contract language, there's an automatic annual escalation that is tied to CMS or some CPI. You may or may not want that. I just think be careful because sometimes that's a disadvantage to you. Sometimes CPI is too little for healthcare services. So how do you take it to the right indicator? Sometimes changes in CMS mean you get less. So just be cautious of that. It doesn't mean you shouldn't have some type of annual escalation clause. Just understand what you're looking at when you actually get to that end date before you sign the agreement. What about language? Prepare your language ask. There are some key criteria that you want to think about. Payment timeliness. What is that? 30-day clean claim? What about overpayment look back? Is there a period of time we can cut this off? There are certain state requirements by the way. I know in the state of Washington, I think it's like 24 days, something like that. But there's certain restrictions, but you want to think about those within that contractual agreement. Also, paid claim stay paid. You shouldn't be 2 years later and they want to pull money back from you. If they paid it, we need to trust that we got paid so that we can move on. We don't want to be looking over our shoulders every day. So just some ideas within this. I won't read it verbatim, but be thinking about that overpayment, underpayment, look back period, that whole prior authorization, what is required of you within the language, and can you successfully implement it? So those are just key concepts when you're thinking of your language and the language components of it. I'm going to dive a little bit deeper, not exclusively, but really, what is that favorable contract language you want to have? So, um, payer shall reimburse hospital even if later it's determined ineligible, provided hospital relied on eligible verification. So they authorized, we perform the services, we should get paid. They shouldn't be able to say, oh, sorry, yeah, you did perform the service, but now we're going to pull that money back. What about amendment controls? Any amendment requires mutual agreement. I have seen contracts in which it's one-sided. They can make an amendment and you are stuck with it. So that's the other side of this. What's unfavorable contract languages? Please avoid these. Payer may amend this a contract within X number of days. And sorry, it's unilateral. It's you or don't have any decision in this. Here's our amendment. Sorry, you're out of luck. That's not good for you. So be careful about that. Payers may offset overpayments from future payments without hospital consent or time limit. So all of a sudden you're 6 months or a year later and you got these payments being sucked out of your current volume pay for things that happened a year ago. And you have no control over that. And all of a sudden now you're in a cash crunch. So understand that when you're looking at your contract language side of it. Here's some negotiations, do's and don'ts, things that you should be doing. Again, a lot of this is again a little bit repetitive, but what are your quality metrics? Do you have enough access? Are you prepared with your documentation? Things that you don't want to do. You don't want to get into antitrust violations. You don't want to talk to other hospitals and say, "What are you getting?" And can I look at your contract? That is a no-no. So I mean, these are just things that I'm sure everybody's aware of, but I thought they were worth mentioning here. So, what are some key rural hospital negotiation levers? Well, number one, I think at your arsenal is sustainability, relevance, right? And that's being there tomorrow for the community, and that's huge. No provider wants to close their door, and no payer wants to be in the national news that they help create that environment. So working with that payer, that's why that payer relationship is so critical. Understanding the whole regulatory political environment, how to avoid some of those downstream cost things that you aren't prepared for. Our cost structures are higher. It's been known. I just saw this in a Turquoise newsletter that rural healthcare get paid 33% less than their urban counterparts, but our costs oftentimes are higher. That's not always the case, but boy, just that whole recruitment and retention becomes challenging. So a lot of times your costs are at least equivalent because you're competing in the same market for providers. And so sometimes it's even harder to get providers in our communities because the quality of life is just less. They got to take more call. There are more disruptions. And so sometimes we have to pay higher. And that's just part of how we should be thinking about negotiating and using that leverage. All right. So potential special considerations. Should I consider a value-based contract? Well, it depends. I mean, are you ready to? Do you have the ability to define your metrics, control the metrics? Are your providers on board with that? Do they have the capability? And so does your staff understand what that means and what's the risk? So just think through that before you just enter into it, and walk through this slide and just understand what you're actually agreeing to. Um, some contract optimization. So here's kind of just some thoughts to think through. This is your phasing approach, 4 to 6 weeks in data collection. So this is best case scenario. I mean, I wouldn't tell you that you can get this done in a matter of even 1 year sometimes. But just be prepared that, this is how long some of this stuff takes, that benchmarking, gap analysis, 4 to 6 weeks, and then ultimately getting executable contract at the end of the day can take upwards of 6 to 12 months after you've done those first 3 phases. So I have seen some contracts take, several years. Sometimes we just don't have that long. So you can do them quicker. I know in past negotiating things, I have done them in a matter of 6 to 9 months. But they're pretty clean. They're pretty easy, and we've had a long-standing relationship. Those typically are your bigger pairs. You're always going to have those one-offs that can actually take like a few days and you can sign it because they want to pay you 95% of charges. But I mean, that's who wants to do that? But those do happen, And so yeah, I'm talking about mainly those bigger payers. I'm going to skip this one, but this kind of gives you a little bit of some of those challenges where rural hospitals are paid 33% less. 40% of rural hospitals are facing negative margins. These are all reasons why you should negotiate. So just for today, you get a bonus section. I added this in here more last minute and thought because Medicare Advantage. So we all know Medicare Advantage is becoming more and more prevalent. We are seeing a lot of different opportunities out there. And unfortunately, Medicare Advantage plans don't often even cover our costs. They want to pay us less than Medicare. On average, across the nation, they want to pay 90% or less than what Medicare is paying you today. Well, I don't know about you, but if we're truly as a critical access hospital just getting our costs covered, um, plus or minus 1%, depending on sequestration. But if you're just basically breaking even, why would you sign a contract in which you're going to lose more money? So they are negotiable. Be thinking about them. And here's some ideas of what you should think about when negotiating that. Do not assume that Medicare Advantage should mirror traditional. They don't. They want to pay you less. You would hope that they would, but they don't. So look at the contract, understand it, be ready to negotiate with it. I've had some Medicare Advantage plans that want to pay me 140%, 150%, and they're different. So just know what you're getting into. There are a lot of different plans out there. Hopefully, if you're going into a Medicare Advantage plan, that carrier knows your market. So some things to think about within that to be successful is what product specific participation are you bringing to the table, defining that reimbursement, using those whole negotiation levers to be able to have strong interactions, create your plan, understand the prior authorization, that retro denial guardrails, make sure that's all in place. If you need, again, any assistance or just thoughts on what this should be looking like, I can provide you more as at any time. Just reach out, let me know. Happy to help give you guidelines. I'm really hoping that I can just at this stage get you to start thinking differently. How do we approach this? All right, we're going to conclude today's webinar just with some other considerations. So something to think about. A contract is really between two equal parties. You as a provider are not less than. You as a payer are not more than or less than. So we are equal partners. We're in this together to care for those population of patients that are under that particular plan. So that should be our number one goal is how do we care for those patients, do it effectively? How do we create this win-win environment that ultimately we can both be successful long-term? Don't be intimidated by large corporations. There might be a lot of hoops to get through. You know your business better than anybody else and know that. You know your clientele more than anyone. So go with that as your primary lever. Ongoing performance monitoring. Are they doing what they said? What's our denial rate? Are we having communication? What's the reason behind that? Is it a game? Is it AI generated? I had one hospital I was working with, and they got a denial on a claim because they said the patient was mobile and could get around. Well, the patient was a paraplegic. They could not. They had comorbidity. They had multiple things going on. But it was somewhere AI decided that they hadn't read the chart or couldn't find it in the chart. So this patient shouldn't be here because they are fine. And so, there's just weird things like that. And so how you're having those discussions, are you going to the table? Make sure your net reimbursement rates or by service line are supportable or understandable. I have a whole nother discussion about the service line review and how to make some of those, more profitable. Some of them lose money and they're really essential, but ultimately, at the end of the day, how could you make them lose this money? And part of that's right here. How you look at that net reimbursement by service line. And then some Advanced contract management, I would highly encourage your revenue cycle team to all be on the same page. So create a metrics that kind of outlines that payer term, understand when it's up for renegotiation, does the payments change? They're really hard to keep up to date. I know we're all busy, but it's really important for visibility for the whole revenue cycle team to see that. Load accurate information into your system so that you're not. I know sometimes you get into these systems in which you're having to chase like it's a $5 variant, and really it's because you don't have accurate information loaded into the system, and so all of a sudden your billers are clogged up with chasing things they shouldn't have to. If we had updated the system, it would have netted out and said, "Yep, we got paid exactly what we thought we'd get paid," and they can move on to more important things. So little guidelines here, um, things to think about within contract red flags in terms of that whole. So reiterating how long before you should think about, walking into a contract, that whole unilateral privilege, what to be cautious of. So these are just a takeaway for you to think about as you head into negotiations, and definitely that contract review before you sign it. So about done here. Your key takeaways today really are developing those foundational principles on understanding what is a contract, what does it mean, why should I even think about entering into some negotiating component? Am I prepared for it? Do I have the means internally to manage that, or do I need to look to an external partner for that? And then your action steps. How do I begin to model this out? So I can create this story to be able to share with the payer as to why this is super critical for us. So remember, 56% of rural hospitals end up paying straight compensations. You're stuck with those. Think about how that impacts your contracts, what that means in terms of your ability to use that as a lever, especially since you're getting paid 33% less than your counterparts in urban areas. How do you begin to bring that chasm together so that you're actually more congruent with what your needs are in order really truly to survive? So I think that's the end of our time. We're getting really close here. I'll see if there are any questions. I do want to remind you this is the 5 pillars of financial effectiveness. We have completed the physician contracting and compensation. We just completed the insurance contracting. Next, we're going to start talking about productivity standards and how it's really not a 4-letter word, but how do you begin to implement this in your organization? So be looking for that coming up soon, probably within the next month. I'll look forward to that as well. It's one of my heart passions really in my career. So looking forward to sharing that with you. I'm going to stop sharing. I'll see if there are any questions, a few chats here. Thank you, Steve. Very much appreciate that. Thanks for joining. Happy to do this. Love it. Thank you again. We'll make sure that you get access to this. So definitely, we'll provide this for you. Any other comments, questions, please throw them in the chat. You're welcome. Great to have you here today. So I'll wait for a few more minutes if nobody else has anything else. Again, thank you all for joining us today. It's been a privilege. I know how tight time is, so really appreciate your time. Jane, thank you for joining. I'm so glad that you could join us today. So thank you all very much. You have a wonderful day, and we'll look forward to having you join the next session.